Welcome everyone. Welcome to another meeting by Empower and Tie Up Together. I am Mehak this side, and we have some wonderful team here who will be helping you forward understand more about type 1 diabetes. And first, first will come Dr. Manisha. Dr. Manisha will share about Empower Type 1, and then she'll introduce the moderator, and moderator will introduce the speaker. So over to Dr. Manisha.
Thank you so much, Mehak, and a very warm welcome to one and all present here. A very good evening, and thank you for taking out time for this event from a very busy weekday, especially. So Empower is all about, like as the name suggests, Empower Type 1. We have the mission to empower all our Type 1 friends. It's a group which is a collaboration of all the diabetes advocates, nutritionists, the educators, physicians who are treating type 1, and lots more. And we aim to do more of research, which is pending from our side, especially in the field of type 1, and how can we make lives better and improve the quality of life to our, like being as a caregivers to our patients and so on. So there is a lot to go, and we will be learning today from our very renowned speakers. To start the flow, I would like to invite a very close and good friend of mine, Dr. Subhajyoti Ghosh. He's a good friend from Dibrugarh. We recently met and we did a fantastic workshop on type 1. The conference was organized by him. And Dr. Ghosh is MD and PhD in diabetes. He's a diabetologist and metabolic physician from Apollo Clinic at Dibrugarh. And he's joined from all the way and here to share all his experience. So thank you, Dr. Ghosh, for joining, and all the stage is all yours. Kindly take the lead. Thank you. Dr. Ghosh, please unmute yourself.
So thank you once again. Thank you, Dr. Manisha, for making me a part of this, because we are all so much enthusiastic while helping our type 1 people, type 1 children. And like in our last conference, we just got to know the chill of everyone, and hence we have come together. So it's a long story for type 1, a long journey. To know about type 1, we need to know about the best practices. It's not about the knowledge which we have in the book, but for that we need to implement it. And for implementations, I think we have one of the very senior physicians, type 1 expert, doctor, and everything like a fatherly figure, Dr. Deepak Dalal, for amongst us, who will be speaking about the best practices for type 1 care beyond the glycemic control. That's important, that it will take. Dr. Dalal will be speaking about the holistic care for type 1 after diabetes control. So may I invite Dr. Deepak Dalal. He is an MD, FICA from Mumbai. He is a trustee and honorary diabetes specialist from Juvenile Diabetes Foundation. He is also a diabetic educator participating in NDEP 12th year program. He has a special interest, lifestyle transformation education coaching with yoga and plant-based diets. And also he was RSSDI task force member for type 1 own diabetes, and also a consultant diabetes specialist endocrinologist in Bharti Arogya Nidhi. So with this, sir, may I welcome you for the stage, and the dice is all yours. Thank you, sir.
Good evening, everybody. Can I share the screen?
Sure, sir.
Good evening, everybody. Moderator, sir, I have 30 minutes at my disposal, right? Hello?
Yes, sir.
Am I audible?
Yes, sir. Yes, sir.
So I have 30 minutes. I'm going to use my 30 minutes in first 10 minutes in just telling what are the things that we are planning to do ultimately, then 10 minutes slides, and then 10 minutes for question answer. So we'll start with management of type 1, and from beginning to end, I want everybody to make one as ONE1 and WON1. ONE1 means body diabetes and WON1 means mind diabetes of everybody, including total society. So we are going to present some pearls in management. I am grateful to organizers, especially Dr. Amit Dey, for this invitation. I shall be addressing my heartfelt feelings. Yes.
Sir, just a minute, sir. So will you, sir, please share the screen in the full slide mode, sir?
This is
This is a Word doc.
it is a word, sir.
Okay, okay, fine, sir.
I will be touching some areas. I will not be reading the whole thing. So I am grateful to Dr. Amit Dey for this invitation, and I shall be addressing my heartfelt feelings of 40 years of my serving children with diabetes, not treating, serving with, and when I say CWD, child with diabetes. The wisdom has emerged from unconditional love and affection given by these children and their families throughout this beautiful journey. On this occasion, I remember with gratitude my mentor, late Dr. Vijay Ajgaonkar, who was popularly called Abba, for inviting me in this beautiful journey. Now, challenge of type 1 diabetes is related to the body of the mind, body of the child, and mind of everybody, child and everybody related with the child. And that we are going to see in subsequent slides. But this particular point is very important. On one hand, child requires day-to-day management of diabetes with the help of blood sugar checking, insulin, at least 3 times a day, lifelong basis, monitoring complications. Initially, it appears impossible. Then it is little difficult and ultimately part of the life. So here, body diabetes and mind diabetes. And mind diabetes either wins or loses. So I am going to give you winning tools and winning arms. So ultimately, who is affected? Child with diabetes, primary doctor and a medical team managing safety in emergency room and day-to-day practice, parents and family, day and night in the house, colleagues at work, workplace, near and dear ones, social encounter, and future spouse throughout the future. So we must be addressing these people's mind throughout and not just blood sugar. And this leads to gadbad and peace. Gadbad means guilt, anger, denial, bargain, anxiety, and depression. With child, family, colleagues, everybody. जैसे बोलते हैं type 1 diabetes है, सुई हरो लेना है, हाँ, that's the reaction of gadbad. And peace, you make it possible by mindfulness. So the management is possible, easy, accurate, convenient, and economic. And this gadbad and peace we will use throughout. Now, why this challenge is important? Because body doesn't have diabetes. So it can be managed by 110%. Body cannot be managed by 100% also. And if not controlled properly or in mediocre manner, it is going to affect all the organs. And more than organs, happy and stress hormone axis, which is very important in management, that I am going to touch, and it affects all the tissues in the body. And T1D means a challenge. Now there is another problem called childhood obesity, giving rise to resistance. So now type 1 is added with the type 2, and that is real difficulty in 18 plus diabetics. So in nutshell, body diabetes and psychosocial, economic, cultural need requiring diabetes, and for that we need a group or we need a community of children with diabetes. So this particular group is required to help the child on a lifelong basis, on day-to-day basis. And where is the real problem? That the caretaker group is ignorant about management of diabetes because they have not seen anybody suffering from childhood diabetes. They know something about adult diabetes. So this particular group or community must be educated, empowered, and evaluated and coached. Coach meaning thereby, if the child is sick, how to do blood sugar, how to give insulin, how to check ketone. So coaching is required. Information must be converted into intelligence and action. And for that, we require a different type of education for this book, for this group. So there is a continuous progress and there is a change in the medical guidelines. So doctor and medical team must inculcate whatever is the latest knowledge in terms of doing, and then as per the country, education, socio-economic status, because in some country insulin pump may be free, but here it is not possible. So the best possible guideline should be addressed in a best manner as per the country, education status, socio-economic status of the child. So for this, we require mindfulness of everybody together. And everybody makes an important piece like a jigsaw puzzle. If one piece is missing or ulta, child will suffer. And at that time, if you do not know proper, keep quiet, keep silent, do not give wrong information and wrong feelings. And that particular silence is precious to the child. And what I mean by silence is all babas and babies claiming cure of diabetes, they should keep silent. Everybody together is a harmony and a music, but if not, there is a chaos and the child will suffer. So with this understanding, how do we achieve this? Blood sugar target, okay. Hemoglobin A1C target, okay. No complication, okay. But what is the goal, purpose of life of that particular child? And purpose of life is required 24/7 by 365 by everybody. So everybody's mindset is on a purpose of life, and then it can be achieved. Now, what we have seen in real life, there's all the children and families who join this support group, they flourish. And those who are separated or lonely, they wither out. And these people who are flourishing, they should take awareness and advocacy ultimately. What we need is a franchisee and boutique approach. Franchisee approach in a medical, everybody should get uniform care. And boutique approach as per the country, socio-economic and cultural state. And what is the most important? Awareness, education, coaching on doing aspects of child, family member, work colleague, near and dear one, medical team, and the whole psychosocial aspect should be taken in terms of coaching. Information is a detrimental. Information to intelligence and action is the answer. So again, from gadbad and peace, we enter the survival, safety, inorganic growth of a child. Roti, kapda, dukan, makan, naam, shan, ये सब होना चाहिए बच्चे का. And then organic growth. My dating, my marriage, my family, and ultimate success. That is, whatever is passion of my life, hobby, whatever I want to achieve in my life, I want to serve the society. I want to ultimately achieve the purpose of life. That can occur by community. And this is a very important message that with the only medical management, you can go alone by self-reliance, apne haath jagannath. You have to help yourself. But to go far, going alone is not enough. To go far, you have to go together. And for that, Sahasrabhuj, 1,000 hands are required to help each other and for that community. So for that, only T1D management is a force and TWN1 is a power. And this power has 4 components: Khushi, of everybody. Khelna, even a family member has to do exercise. Khana, healthy. Even family member has to eat healthy. Khojna, that is a medical checkup of social checkup of family members. Because if they are bad, they will give bad treatment. And Dena, lifestyle where everybody as per lead. Lena, no tablet in diabetes, no premix insulin in diabetes. Sui, procedure and surgery as per early preventive awareness and assessment, and for correction and prevention of long-term complications. So we should participate in creation of such community, maintenance, progress, happy, healthy purpose of life, and development of community. In the end, only one carry home message. Please accept, know, and spread awareness about this particular challenge called child with diabetes and type 1 WN1 diabetes, and satsang or a community for imparting this. And very acid message: if you do not know, keep quiet. Do not be a block to this challenge. And at that time, your silence is valuable. After this, I am going to show you some slides which will be eye-opener, and then we will have some time for question answer. So beyond blood sugar, type number 1 to WN1, and the whole challenge is, my challenge is today type WON1. And my mentor, Dr. Ajgankar, used to say, Abba, जानने की बात है, मानने की नहीं, करके देखो. And here is a conclave at Aurangabad last year, group of community of doctors helping and community of the patients helped. And this is a car accident, this is me, and again back to normal. So same thing, this particular child is attacked, entangled, and ultimately together they win and they have their family. So we have 4 steps: Suraksha, Sasaktikaran, Samruddhi, and Samvardhan. This is Samruddhi, Roti, Kapda, Dukan, Makan, Namshan. But at the bottom of everything, there is a daily safety. And initially life is like this, sinking, then somebody saves, ICs you to ward, and then in the society, and then back to their own family. Initially like this requires a severe protection, then like a orchid, and then like a banyan tree. Well-managed, empathized, empowered diabetic is like a banyan tree. So the help comes from the heart, and it helps in all directions. So our problem is quantitative, unorganized mass, undiagnosed mass, and unknown mass. And from that, we have to move with the community to organize, diagnose, and known. So Agnan, Avyavastha, Aniyamit, Akilapan, or Tutna, Asamadhan. This is mind. And for that, the answer is going together. And again, Khushi, Khelna, Khana, Khojna, Dena. See, these are the very simple appearing words, but in consultation and building up their tempo, these are absolutely must. So the challenge is very high sugar. This we will skip. Now, child needs help at play, school, party, traveling, everywhere. We have to help the child. And there is a snack and there is a ladder. So we have to remove the snack and you have to increase the ladder. And the ladder is a community and the snack is a loneliness and Baba Baby team. And everybody is required and we have to empower. And the problem is, हाँ सब मालूम है लेकिन होता क्यों नहीं है? And the why me and all the claims, different types, right? So what is the first step? Accept it and come out of problem and then enjoy. And this is a really mental problem. We will not touch this aspect because of time. Here is a power versus force. So the power is managing type 1, force is managing type WN1. And that Gadbad slide I want to show, there is a number technically approved. Guilt, anger, denial, bargain has a different negativity, and the peace has a different positivity. And so guideline will not work. We have to focus on goal of life, purpose of life, happiness, healthiness, Gadbad and peace. This is one, and this is WON1. How many minutes I have more? Can I be told? Hello?
Yes, sir. 10 minutes, sir.
10 minutes. Okay. So I'm in my time. So we will see this.
चल उड़ जा रे पंछी
Am I audible?
Yes, sir. Yes, sir.
Okay.
चल उड़ जा रे पंछी के अब ये देश हुआ बेगाना चल उड़ जा रे पंछी अब वो मस्त हवा वो उड़ना डाली डाली भूल जा अब वो मस्त हवा वो उड़ना डाली डाली जग की आँख का कांटा बन गई चाल तेरी मतवाली कौन भला उस बाग को पूछे कौन भला उस बाग को पूछे हो ना जिसका माली तेरी किस्मत में लिखा है जीते जी मर जाना चल उड़ जा रे पंछी के अब ये
So this is a dying child, dying family in community. Now we are coming to what happens if the positively oriented community. Just see this. So am I audible? Hello?
Yes, yes,
Okay.
sir. You're audible.
So these two videos speaks beyond my heartfelt feelings that what happens without community and what happens with community. I have resolved to myself that I will be visiting 84 different destinations in India for spreading this particular message for body and beyond the body. And for that, I am willing to travel anywhere in India. Just I am a phone call away, and we will organize whenever we can help in best of our manner. So here I stop my presentation, and I am ready for the question answer. So sir, I am back to you.
So it was a wonderful presentation. That's it's not like anything which you will be looking regularly in our textbook. It's something with your experience being shared, and some of those slogans are very catchy. I hope like our Type 1 attendees or Type 1 educators who were there in the show will be very much helpful for them. Sir, for question answer, sir, we will go at the end of the session after completion of the second
No
talk.
issue.
Then if there's any question answer, we'll go for that, sir.
No
So
issue.
with this, because already sir have taught a lot about the social aspect, philosophical aspect of type 1 and all these things. So now being in type 1, we should know that type 1 can occur at very early age, and for that to monitor the growth, and we need a growth chart. Because we also do know that because of frequent hypoglycemias, it may affect our growth hormone, hence this our growth chart may be affected and we may have a red flag sign. So what to do, what not to do, and how to assess that. For that, let me welcome Dr. Mayur Agarwal from Bhopal to talk on about the growth chart analysis in type 1 diabetes children. So Dr. Mayur Agarwal is a life member of Vesicon, also a member of IMM, also the member of MCI. He's a speaker in UPRSSD virtual conference in 2020 on hormone disorders. He's a speaker in IMA Con Hadra in January 2021 on diabetes management, and is a regular speaker in Novo Insulin CME. So with this, over to you, Dr. Mayur Agarwal. Thank you. The dice is all yours.
Yeah. Good evening, everyone. Just let me share my screen. I hope my screen is visible.
Yeah, it's visible.
Yeah. Thank you. Thank you for the invitation, and thank you, team, for organizing this. My topic is more of scientific after this much of a social lecture. I meant to educate not only the caregivers. This is more of a more technical sort of lecture today. So the maybe doctors also would be enlightened by this lecture. Most of us caring for type 1 are actually not MD pediatrics. So not many are well versed with the growth chart. So that is what is my talk today regarding the growth chart, especially in type 1 diabetes. Okay, so and not only this, what I would be telling is how to plot a growth chart. Why are we so concerned about growth chart? What are the things we can look at in the growth chart? And all the basic things. That is what I'm going to talk today. So in general, if you talk about what is growth chart, so a layman definition would be it's in graph. It's plotted like a graph only, right? It's a graph paper on which it is printed, right? So it's a graph on which anthropometric parameters, that is height and the weight of the child, are plotted in accordance to his or her age. So we have a blue chart, we have a pink chart, pink for the girls and blue for the boys. And on that, we have some parameters, and against which normative data, we see that where this patient or where this child is standing. Okay, so why are we so concerned? Because this will help us to diagnose regarding the short stature, also regarding obesity. Now, both is a problem, and obesity is rampant, not only in general, in type 1 also we see obesity, right? So that is again very important. And not only this, again, we would be also able to tell regarding the final adult height, that is follow up of the height or the final height what the patient could gain. It may be very important for somebody, because let's say a type 1 is planning to go in sports, or maybe he's planning in army. So in that times it would be very, very important, right? Now, what is short stature? So short stature in general, if you say in a layman term, in a very basic definition, is that child height is less than what it should be. That is your short stature, right? I'll tell you more the scientific definition later on, but that is what is the basic thing. Okay. Now, how do you define that? What should be the child height in final height, or what should be the present height for this child at this time? So height is in accordance to the age, in gender, and height of parents. So it is again very, very important. Okay. Somebody who is having both the parents are tall, he would be taller, right? But again, there is a law of regression that we tend to move towards mean, that a child who has a very heighted parents will have a slightly lower height, and those child who have a very short parents will have a slightly higher height. That is, we move on to regression towards mean. That is what is it is. And then there's something called mid parental height, where we do an average sort of thing for both the mothers and father height. Okay. And this is your growth chart. This is the latest what is available. So you can see here that here on the x-axis you have age in years, and this is a blue chart, so it's for male, and this is a pink chart, that is for girls. And on the x-axis you will see that you have age, and in between you can see that there are few smaller lines also. Accordingly, you will plot it here, like let's say 1.5 year, somewhere 1 year 6 months, so you have to follow this line. Okay, so this lower one is for weight, this upper lines are for height, and this small box, this is for your obesity. Okay, we don't do here BMI sort of thing. Exact that height and weight, that is not the ratio what we take here. Okay, so weight upon height square is not how you define obesity in children. This is through this graph how you define that the child is obese. Similarly, here is for female, and this is for your mid parental height, where you join the mother and father height, you cross it, and then you see what is the mid parental height. Now, in further detail, if you see, you will see here percentiles. So this is median, that is 50th percentile. I hope this is visible. And that is 75, 90, and 97. Okay. And then similarly, you have here 25, 10, and 3. Okay. So somebody who is below this 3 is what is, but slightly lower. Okay, so we do something called as mid parental height. I am coming to that again. And this is your 50th percentile. So 2 standard deviation is what you take. And somebody who is below this 3 line, this black line, this all red lines, that is where you see that this patient is short. Okay, so this is very basic of growth chart. Any pediatrician would know it. Okay. Now, to know the abnormal, you should be knowing the normal. So how did you come to a conclusion that this is the normal height? So you follow the same thing, the Gaussian curve. So anything which is within the 3 standard deviation, that is normal. As normal, 2 standard deviation is what you take as normal, and less than that, that is 2.5 percentile, what valid for almost everything, whatever you see in biology, like let's say your TSH or your creatinine, whatever you say, but it's not valid for diabetes. Okay. So diabetes, the normal sugars are not defined like that. Otherwise, every time only 2.5% of the population would be diabetic. So diabetes definition, that normative data comes from complication. Okay, whereas most other parameters comes from the normal distribution curve, that is Gaussian curve. So anybody who has height less than 3 percentile or less than 2 standard deviation for the age and sex, that is abnormal, and that is what is defined as short stature. So that's the actual definition of short stature. Now, there are 3 basic terminology which you should understand. First is the chronological age, second is the bone age, third is the height age. Now, let's discuss one by one. What is chronological age? Chronological age is from your date of birth, is many months. That's your chronological age, depending on the month calendar, right? So that calendar age is your chronological age. Now, what is your height age? So let's say is somewhere falling here let's say he has a height of 120. This is a blue chart. Okay, so we are plotting for a male. Okay, so this is somewhere 120, right? So this 120 is falling on the 3 centile, right? Or even lesser than, let's say, 115. The boy is 115, something like that. Let's say 115. Okay, so this is obviously short, right? But what is the height? Okay, so this height age, that means this height should be attained, median age would be 6 years. At that, the child would have 115 centimeter. So that is your height age. Now, what is your bone age? Depending on the X-ray, I am coming to that. We define that what is the bone age. So these three are really important to make a diagnosis that what the child is suffering. Okay, so this is the basic. I'm not going into too many details because it's more of endocrinology. What we are discussing is just type 1. I'm coming to that. So short stature can be a variation of the normal or can be pathological. It can be proportionate, disproportionate. Some skeletal dysplasia can be there, and it let's say Cushing's, then also the patient can develop secondary diabetes. So they can be associated with diabetes, but not typically type 1. And in type 1, you can have malnourishment, which can lead to short stature. And then chronic disturbances of GI, renal. Let's say the patient of type 1 developed chronic kidney disease. Again, that patient can be short. Or let's say the patient developed some hypothyroidism, endocrinologic disorder. Then that patient can be short. Or let's say the patient is developing celiac disease. Again, it will cause malnourishment and can lead to proportionate short stature in a patient of type 1 diabetes. Okay, now this is very basic of any endocrinology talk, that is familial short stature and constitutional. I'm not going into great details, but the basic thing is that in constitutional short stature, there would be delay in puberty. Now, this makes us discuss one more very important aspect, that in every type 1 diabetes, in every children, you have to assess puberty, and then only you would be knowing that what are you dealing with. Now let's talk about etiology. So it can be malnourishment, it can be chronic systemic disease, CGDP, FSS. Just now I have discussed some endocrinology disorders, some skeletal dysplasia, some other chromosomal disorder, syndromic, all those can be there, right? So a clue would be what I have discussed is regarding your bone age, height age, and chronological age. So chronological age would be obviously higher. That is what you're dealing, that at that age, the patient is not gaining that height, right? But if the bone age is proportionate to height age, probably you're dealing with malnourishment or chronic systemic illness. So that can be a case in type 1 diabetes, especially poorly controlled with dysglycemia, but very poorly controlled diabetes. This is where the type 1 diabetes would fall. Okay, and then if the bone age is very less, probably you're dealing with an endocrine disorder. Maybe it is a secondary diabetes, maybe it's an hypothyroidism in diabetes, maybe it's hypogonadism. Something is happening other than that also. So here the bone age would be too much delayed as against to your height age, as against to your chronological age. Okay, and then both disorder would be very easily picked up because of the disproportionate short stature. Now, whenever you see a patient of short stature, you must you must ask about the prenatal history, whether the full-term delivery was there, whether there was a breech delivery, because breech delivery can be associated with growth hormone deficiency. So birth history, milestone are very important. Okay, then the family history is again important. I've already told you about your CGDP. Then nutritional history is again very important. Then systemic disease, you should ask for history also. You should examine in complete detail. And even psychosocial factors also influence your height, nutrition, all those things. And in examination, you have to see the height, weight, you have to plot. You cannot say just by seeing a child that this is short, right? You have to plot it, you have to define the standard deviation, everything. And then you have also to see the upper and the lower segment ratio. There are n number of differentiators. I'm not going into this. Then dysmorphic feature you should be seeing regarding your growth hormone deficiency, all those. There can be some central incisors, some cleft lip, cleft palate, all those can be there, right? Nutritional status is again important. Thyroid, you should always palpate in these type of patient. And then systemic examination for, let's say, a heart failure, or maybe a chronic kidney disease, or maybe just an anemia, very simple. And anemia can also lead to short stature. So all those things should be looked at. And very important is to do staging for the puberty. So how to measure height is again very important. So we measure by stadiometer. Ideally, you should take 3 reading, then you should do an average, and then a Frankfurt plan, that is the outer canthus of the eye and your this meatus should be at a line which is perpendicular to the standing person, and then this occiput should be touching, back should be touching, and your foot should be touching the stadiometer. So that is how you take an height, because if you do this wrong, that the height is measured wrong, everything would go wrong, right? So first basic thing is to take the height very properly, correctly. Ask to remove the shoes, because sometimes with very high heel something, the height is taken. So all those things are very wrong. So that should be taken care of. Okay. And then a mid parental height you should be taking. So you can do for males, what you do is father plus mother plus 13 divided by 2, and in for females you just do minus 13 divided by 2. Okay, the same thing is written here. Either you can divide first and then add or minus 6.5, that's the same thing. Okay, so this is your mid parental height, and accordingly you decide whether the patient is going right or not. So target height is basically 5 centimeter above or below your mid parental height. So if the child is following that, it's more or less the patient is growing normally. Then bone age is done by taking an X-ray. Usually what we do is an left hand X-ray. That's the standard protocol what you do. And then you have something, a graph, you have a paper booklet where different radiographs are there, and you match them with the patient's hand X-ray. Okay. And accordingly you decide that what is the age. Now we have some softwares also, but that's the standard method what has been done since ages. Grulich and Pyle chart is what is seen, and then you decide that what is the bone age of the child. Okay, so if bone age is delayed, then probably you're dealing with some endocrine disorder. And then this is a Tanner staging. Again, I'm not going into details. So this needs some of the experience, that when you see too many patients, like you palpate for thyroid, you palpate for the testes, you see for palpate for the breast, then only you will be able to pick up all those small things. So this is your Tanner staging of puberty. Okay, again, we are not going into great details here. What investigation you should be doing in this type of child? So hemogram is a must, because see, anemia itself can lead to short stature. Thyroid function is a must, because this is very common in type 1. Hypothyroid is known, and there is a strict guideline that every 2 years you should be screening. Then KFT, LFT, all those are important. Potassium is again very important. Celiac screening, especially if the child is falling short, a celiac screening is mandatory for this type of child. Okay. Then ABG or VBG, then stool for overcyst, all those can cause malabsorption. And then advanced tests may be required in few cases, like your IGF-1 insulin, like growth factor, or your growth factor binding protein 3, which is from the growth receptor, or sometimes we may need karyotype. Sometimes we even need dynamic testing, and that's a second line test when we are certain that probably this patient is having growth hormone deficiency. And after that, even we may need imaging that patient may harbor some pituitary tumor, something like that. Okay. Now let's talk about what is the association with type 1 diabetes and height. So whether type 1 itself causes reduced height, it is very, very debatable. There are controversial studies, conflicting literature on this height parameters for children with type 1 diabetes. Now let's discuss what is the data from India. So I could come with two studies. This study, this was published some 20 years back, where 125 diabetic type 1 patients were taken, and they were matched to healthy controls. The mean age was 9.7, and there they saw that the diabetic children, they were slightly lesser, 128 centimeter versus 133 in the normal population. So average height and average weight was lower, and diagnosis, especially if type 1 was diagnosed less than 3 years of age, they were even more shorter. And when the age of diagnosis was more than 14 years in type 1, they tend to be normal. They were not short. And then again, a very recent study in 2023 only, it was 2022, it was published. This is from the Andhra, where 57 type 1 were studied, and they were again compared to the normative data. So the median age of diagnosis in these, median age of inclusion was 13.8, and the duration of diabetes was around 5 years. And what they found, that the height average and the weight average and the BMI average, that was lower in type 1 diabetes against the normative data. But age of diagnosis what not affecting this data. Also, the duration of diabetes was not affecting. Also, the type of insulin was not affecting, and whether the strict control or not strict, whether the patient going into intensive or the conventional control, that was also not affecting the height. Okay, so overall, it is very, very controversial whether the type 1 diabetes itself causes, maybe poor glycemia has some effect, but otherwise, especially just type 1 diabetes with very well controlled diabetes, it's not a very strong pointer that the patient will be short. But if type 1 diabetes is falling short, what you should look at is celiac disease and hypothyroidism. This you should not miss. So again, this helps us to diagnose this patient, and that's an indication that you should do testing for these patients. So I think the session was helpful. We can have more of discussion because this is a vast topic. We can go for short session like for more than 2.5 hours.
Thank you, Dr. Deepak. This was like really a good. And yeah, we know that, but if you start talking about growth chart and type 1, that will somehow will switch to short stature, and that can again lead with a lot of other things. But just to get the things so much simplified for our people living with type 1, we are not. I'm really thankful to you. You're not confusing with a lot of other diagnoses. So there are a few questions. Can you see me in the chat box? So let's take one by one so that we can end up in due time. So there was one question that which has been saying directed to our Dr. Dalal sir, and it's saying ki anyway, so that was not for your question, so that was like about your presentation. They are saying that the presentation was very superb with so much of uh, habit forming activities which you have said for our type 1 diabetes patient. But so there is a question along with that. What about the smart insulin and weekly insulin for type 1 diabetes patient? I think either of our speaker can speak on that.
Weekly insulin is not yet available in Indian market. So let us not talk anything on that. If Dr. Mayur has different view, he is welcome.
So I think weekly insulin would be available by next year by the name of weekly. Novo is introducing it, ICODAC, and there are good trials that it may be helpful with not much of hypoglycemia. There are some studies on that onwards trial, but one of that had more of hypoglycemia, but again, it depends on patient to patient. So we'll have more of evidence and more of real world evidence, especially once it is launched. It is not launched anywhere in the world actually.
Sir, just to add on, FDA has disapproved weekly insulin for type 1 diabetes.
Type 1, that's important. FDA have really disapproved for type 1s.
So they are still collecting on data. It's not launched anywhere in the world actually.
And what was the rationale behind for disapproving?
Ma'am, this weekly insulin is more likely like a basal insulin, which can help in type 2 diabetes. But in type 1 diabetes, since there is no insulin being produced by the body, so they refused it, saying that bolus would still be required. And just like we have Tresiba, which is a 42 hours insulin, still a type 1 has to take it every 24 hours. Even if they create weekly insulin, a type 1 will have to take it every 24 to max 48 hours for usage. So there cannot be weekly insulin as of now for type 1 diabetes.
And my primary question is, suppose child develops hypo and child refuses to eat as per the schedule, what can be done? This is a practical real life problem. Child has taken weekly insulin, now not eating. वो हड़ताल पे क्या करेंगे?
Sir, prior your questions, I would like to say that when this have not been approved, we better should not discuss about it.
We should not.
Because with
So we go
discussion,
next.
false information will continue.
Yes, we go next.
So there sir, is one more question is that hi, good evening, sir. I am type 1 for 24 years. How can I prevent myself from neuropathy? Nowadays, I'm suffering from frozen shoulder pain. So any of the speakers can talk about it, or any of our panelists also can talk from there.
So
Okay,
Dr.
so I'll
Manisha,
take this. Yeah. Since it's
please.
having frozen shoulder, so that itself says that his sugars are not being controlled. So he need to control his blood sugar reading by doing regular SMBG and get himself checked for HbA1c and the investigation which has been proposed. And second thing is like, how can you prevent? The जड़ जो है वो शुगर है, शुगर अच्छा रहेगा सब चीज टनाटन बना रहेगा. So this is the high most important, like this, just control your blood sugar reading and you will surely not fall into any complication related, either it is microvascular or neuropathy, retinopathy, nephropathy, autonomic neuropathy and peripheral vascular disease and so on. So just control your blood sugar reading and you will be fine.
So, I would like to say that being type 1 for 24 years, yeah, you are a fighter still. You can still continue your journey with controlling your blood sugar. Frozen shoulder can be just a part of your a bit early warning sign that you have to take a better control of your own blood sugars. So, with that,
So,
there comes the next
sir,
question. How
so
to?
Dr. Ghosh, Dr. Dalal wants to add on to something. Yes, sir.
Yes,
Please.
sir.
suppose he is doing better. He thinks that he is doing better with the SMBG. Then he must go on CGMS and see for himself how good is he, and the better evaluation with the CGMS will change the scene. That is what we have seen after using CGMS. हम सोचते हैं कि हम सही कर रहे हैं, लेकिन वो सोच है, वो होता नहीं है.
So that was
CGMS
the
is a very
question
good tool.
actually. So that was the question which has already been replied by you, that how to manage a blood sugar. So first thing is monitoring, which you have already said. And after monitoring, the rest of the things have already been discussed, but still I would like to take a few crisp points from all of our faculties, like how to manage blood sugar in very crispy way.
My take would be just one line. You have to manage your diet and insulin. इसका एक बढ़िया तालमेल बैठाना है और वही डायबिटीज मैनेजमेंट है.
From Dalal sir,
हाँ, मेरा 4 पहिए का गाड़ी है. खुशी, खेलना, खाना, खोजना और देना लेना. Kushi means you should be happy about your diagnosis and treatment tools available. That is not punishment, that is your power. Khelna means exercise is must, morning, evening. Khana means healthy eating and not diet. And healthy eating by family and healthy eating by child. And khojna means monitoring. And dena means lifestyle, lena means injection. So if all the first 3 wheels are balanced, then the last karigari will help. कारीगरी लास्ट से चालू होता है, वो नहीं चलता. So that is my tip.
so there is one more, there are a few more questions. I'm taking one more questions now. My daughter is 17 years, but her periods haven't started. Is it because of type 1 diabetes? Like, please enlighten us. And to our attendants, to attendees also.
Dr. Mayur, you can take this. This is more of endocrine.
Yeah. So yes. So it can be anything. We need to evaluate. This is a very non-specific question. We have to evaluate. See, not getting periods up to 17 years, even with the secondary sexual character, is abnormal. Okay, so we see first for whether the patient is developing secondary sexual character or not, and then we evaluate. So it's a primary amenorrhea. It can be anything from premature ovarian failure to something else also, right? So we need to evaluate. It's a very non-specific question, I would say. You should consult and we need to examine the patient first.
So with that, I would just like to give a suggestion to the mother of the daughter that please consult a nearby endocrinologist. So that will be a better. We don't know like whether the daughter is a type 1 diabetes or not. We
It's
don't
not
know.
a normal thing for type 1 diabetes. You should not be ascertaining that everything is due to type 1. It's not due to type 1.
So in that case, we can also add that like having a diabetes, primary amenorrhea, there might be some other syndromes associated in that case. So it's better to go to an endocrinologist nearby. So there is one more question like,
Dr. Ghosh, you
how
missed
can my
question 5. ये हिंदी में है. Shall I read this?
please?
I know it might be tough for you. कोई डायबिटिक पेशेंट है जो सडनली गिर गए और साथ ही बेहोश हो गया और हमारे पास हॉस्पिटल में रिगार्डिंग कोई भी फैसिलिटी अवेलेबल नहीं हो, तब उस सिचुएशन में कैसे समझेंगे कि पेशेंट की शुगर कम होने की वजह से पेशेंट गिरा है या शुगर बढ़ने की वजह से गिरा है? सर, दिस इज फॉर यू.
So my answer is, what is first, egg or a hen? Or what is a seed and the tree? This cannot be answered. Unless and until, we have the full spectrum, we have done the blood sugar and child has recovered fully, right? Even then, after that, we have to find out that why. So
Yeah.
it is a clinical puzzle. You cannot say because of this.
My take would be probably it is more of hypoglycemia if it is sudden. If the patient is breathing very fastly or has fever, something you saw that the patient had vomiting, then it may be something else. Otherwise, in type 1, you consider that this is hypoglycemia. You treat it as an hypoglycemia. Do not give anything orally. ऐसे मरीज को कुछ भी मुंह से नहीं खिलाना है क्योंकि वो सांस नली में जा सकता है. What you should be doing is a glucagon injection, which everybody of us know, and your trainer would have told you. Let's say you don't have glucagon also. What you can do is make a thick paste of glucose, apply in the buccal cavity below the tongue. That will solve the problem.
And if you do not have a glucose, just a powdered sugar, because
That is
saliva
okay.
has a ptyalin, it has a power to convert disaccharide into mono in few seconds, and it works out. शक्कर किधर भी मिलेगा, ग्लूकागॉन ग्लूकोज नहीं मिलेगा, शक्कर हर घर में है.
Can I come in with a quick experience share on this? This is not related to type 1, but this was an experience which I had recently when I was traveling to Jaipur in flight. And we had a similar experience that a patient had collapsed midair in the flight, and there was no glucometer in the flight. And the only thing that the patient's wife could tell me was that he was a diabetic patient and he is on insulin. So I literally had to guess. I mean, patient was semi-conscious. I literally had to guess that this is a hypoglycemia, which the patient has had. And I exactly did what Dr. Dalal just said and Mayur just said. We took sugar powder and we just put it in, just on the surface of the tongue. And after that, after a period of time, he was a little better. And then we had that sugar water and he drank that. And luckily, the plane didn't need to do an emergency landing and he was up and awake. So, and I completely agree. Most of the time, it's hypoglycemia that causes this rather than any kind of a hyperglycemic surge, which is very unlikely.
One point I want to add. So this person wants to know कि बाकियों को कैसे समझ आएगा कि उसको hypo हुआ है या hyper हुआ है. Because sometimes, being a type 1, we are traveling or something, we are outside our comfort zone and something like this happens. Generally, we have our diabetic cards. आप अपने डॉक्टर को भी बोल सकते हैं, आपके डॉक्टर्स आपको डायबिटिक कार्ड बना कर देंगे जिसको आप हमेशा अपने साथ कैरी कर सकते हैं. There is something known as diabetic band or diabetic necklace which you can wear. इंडिया में भी लोग बहुत ज्यादा अवेयर नहीं है, but diabetic card is what people are aware about, and I think it should be used by every type 1. You should have a diabetic card.
Diabetic card and 3 teaspoonful of powdered sugar in upper pocket all the time.
So true.
Yes. Next question, sir.
So just going back to next question. So it's how can my child get relief from day-to-day syringe pain? I give insulin 3 times a day. So I think any of our experts can talk on that.
ये चाइल्ड का प्रॉब्लम नहीं है, ये माँ बाप का प्रॉब्लम है.
Exactly. So I was just waiting for your prompt reply, sir.
It requires a psychiatrist.
If I have to say it in one line, ना बच्चे पे दया करना इतना, because there are things we have to deal with. Being a type 1 myself, 3 injections are, I would say, very less. You are just sustaining the child. To live a healthy life, we need more than 6 injections in a day, which I'm myself taking. And if my parents keep feeling sorry for me, I would not have the ability to come and speak here or be at any place. I would be in my room, in my bed, not doing anything. So, daya karna chhod do. Your child has lot of other capabilities, and One thing which Dr. Anju Virmani taught me, I would like to quote here. She said beautiful thing कि अगर पेरेंट्स को लगता है ना कि इंजेक्शन से पेन हो रहा है तो उनको बोलो एक बार अपने आप को लगा के देखो कितना सा पेन होता है. वो पेन इतना सा है पर हम उसको इतना बड़ा बना देते हैं. So that helps a lot.
That particular shot will burst their air in head.
Right.
So
Next.
there is the next question coming up. So prior to that, can I ask to our USB team what is that time duration for this webinar? Is it 1 hour or beyond that?
Sir, as soon as much you can question take, I mean, we have enough questions. So just take the important last 1 or 2 question and then maybe we can, close.
Okay, fine. So we are allowed to take another 2 or 3 questions. Fine.
Yes, yes.
So there was a good question like exercise is helpful for type 1. So does it for short stature with type 1? So I think our either of the speaker can
Dr. Mayur
talk
will
about
answer.
it.
I think
Yes,
that's
see, exercise without type 1, with type 2, without type 2, it is good for everyone. So needless to say, and exercise increases your growth hormone, but that does not mean that if the patient is short, doing exercise will just make normalize everything. So it's a particular investigation, set of investigation which we need to follow. It's a particular algorithm what we evaluate a patient, and accordingly we decide that what is the cost, and accordingly we treat the patient. But in general, exercise is good for not only your sugars, for your mental health, for your bones, for your muscle health, for your balance, for your fall prevention, for your osteoporosis, everything, and even for your mood, right? So it is important and it should be done.
So in between all these things, we also got few suggestions and few comments regarding like Thanksgiving and about the presentations. It has all been good. But with that, I think like there are one more questions, which like it's like a story of a type 1 patient who got married to a type 1, and they had a little 5-year young type 1 warrior who was diagnosed at the age of 13 months, and he is GAD antibody positive. Now they are asking about what can be the recommendation for type 1 patient who is having lactose intolerance, how to manage the diet and other aspect of his life, like just a young 5-year-old type 1 warrior.
I have one simple comment that human being is the only animal who is drinking milk of some other animal. So lactose intolerance is a blessing to him for not having a milk.
100%.
That is a simple answer. He has lactose intolerance, so we have to avoid that. What's bad in it?
No.
And there are enough plant-based milk substitutes which are exactly like or better than milk, more healthier than milk, because nowadays milk that we have is a chemical or real milk, we do not know. But if they prepare almond milk or a coconut groundnut milk, they are healthy and very good options. So this is a very simple answer and doable answer.
Just, sir, one question. The person who has shared her own story, I think her concern is that is type 1 hereditary or autoimmune, because she believes that she was autoimmune, her husband was autoimmune, and now that her son has it, does it make type 1 hereditary? So her question is type 1 hereditary or autoimmune? Mayur sir, if you would like to answer.
Yes. So see, obviously there is association, but for type 2, it is much more than type 1. We have n number of HLAs which are associated.
Dr. Mayur, better you give the answer in Hindi. I request you.
Okay.
This is a very important question.
टाइप 1 जो है वो हेरिडिटरी उसका एसोसिएशन है, टाइप 2 का और ज्यादा है. बहुत सारे ऐसे HLA मार्कर्स हैं जो कि टाइप 1 के साथ एसोसिएटेड हैं, और कुछ HLA मार्कर्स ऐसे भी हैं जो टाइप 1 को प्रोटेक्टिव बनाते हैं। अगर दोनों पेरेंट्स को टाइप 1 है तो इंसिडेंस जो है वो टाइप 1 का बढ़ जाता है, एक पेरेंट को है तो थोड़ा बढ़ता है। अगर ट्विंस हैं, उसमें भी मोनोजाइगोटिक और डाइजाइगोटिक ट्विंस करके चीज होती है कि एक ही ओवम से बने हैं या दो अलग अलग ओवम एक साथ फर्टिलाइज हो गए हैं, तो उसमें भी इंसिडेंस अलग अलग है। अब ये जो है ये ऑटो इम्यूनिटी को प्रोन करता है, जैसे पैथोफिजियोलॉजी जिसमें ऑटो इम्यूनिटी जो है वो डिसीज प्रोग्रेशन कर रहा है, राइट, और हेरिडिटरी कॉज है जो कि इसको ऑटो इम्यूनिटी को दैट कॉजेज की एंटीबॉडीज है। अब कितनी एंटीबॉडीज है, कौन से प्रकार की एंटीबॉडीज है, उस पर डिसाइड होता है कि बच्चे को कब डायबिटीज होगी, और उस पर ही बहुत सारा डेटा है, बहुत सारी स्टडीज है। बट ये सब भी प्रोबेबिलिटी की बात है, मेडिकल साइंस में जो भी हम बात करते हैं वो प्रोबेबिलिटी में बात करते हैं। ऐसा इसमें ये नहीं कि होगा ही होगा या नहीं होगा नहीं होगा, ऐसा नहीं होता है। ये सब कुछ प्रोबेबिलिटी की बात होती है।
द रियल आंसर जो पेरेंट को जो जवाब चाहिए है वो ये है, जब चिड़िया चुग गई खेत क्या करे। इट हैज हैपेंड, सो इट हैज हैपेंड नाउ, look forward to deal with it rather than finding a cause. Cause is for scientists, cause is not for parents. For parents it is a grateful and a graceful acceptance for a future purpose of life of a child and not crying the past. And
सर
for
आपकी बात
this
बिल्कुल सही है कि इसको
importantly,
टाइप 1 को प्रिवेंट करने के लिए कोई रास्ता नहीं है, इसलिए वो टाइप 2 की तरह सोचने का इसमें कोई मतलब नहीं है, कॉजेज ढूंढने जाने का अभी कोई मतलब नहीं है। जब तक हमको प्रिवेंशन की तरफ हम आगे ना बढ़े तब तक कोई मतलब नहीं है, क्योंकि इसको ट्रीट ही करना है अभी तो।
that
ग्रेट।
advertisement is
एंड
there,
नोइंग द कॉस्ट
ढूंढते ही रह जाओगे।
एंड नोइंग द कॉस्ट डज नॉट चेंज द ट्रीटमेंट। आपका कुछ भी कारण है, ट्रीटमेंट वही रहेगा। तो जो भी मेडिकल साइंस में जो भी हम टेस्ट करते हैं वो इसलिए टेस्ट करते हैं कि उसका कोई इंटरप्रिटेशन हो और उस पर हम ट्रीटमेंट चेंज कर पाएं, उस पर हम कुछ एक्ट कर पाएं। अगर हम कुछ एक्ट ही नहीं करना है, जिस रिपोर्ट के बाद भी वही ट्रीटमेंट देना है, तो उस रिपोर्ट का कोई मतलब नहीं बचेगा ना।
तो अभी लाइक हम
Sir,
लोग हमारे जो क्वेश्चन आंसर है वी विल बी वाइंडिंग अप, बट देयर आर टू वेरी स्वीट क्वेश्चंस। एक क्वेश्चन ये बताया जा रहा है कि बच्चे को हाइपरग्लाइसेमिया है, क्या वो एक्सरसाइज कर सकते हैं उस वक्त या नहीं?
sir, I think both questions can be clubbed together. If a
या
child has glycemia or ketones, can child exercise?
No. If sugar more than 250, do not exercise. It will further worsen the sugar control. And if ketone, forget it. And similarly, treat the hypoglycemia properly, achieve normal blood sugar, and then do moderate activity and not severe exercise. This is very clear-cut instruction, not answer.
Also, a very good thing people believe is that exercise brings sugar down.
Right.
Exercise only increases insulin sensitivity. So if there is no insulin in the body, no amount of exercise can help you bring
The
sugar.
answer is type 1 diabetes is insulin deficiency diabetes, and it is not insulin resistant diabetes.
Right.
Here, the deficiency is the problem. And if child is obese, even then, type 1 obese, he has to follow these instructions.
Very true.
I just want to add one point regarding that question that came in regarding the lactose intolerance in T1D patients. I presume we have a lot of physicians who are listening to this, and you should all be aware that with the autoantibodies being positive in the T1Ds, there is a good prevalence of celiac disease as well. So they need to be screened for that. And one very common, test that you can do is the hydrogen breath test, which actually helps you exclude SIBO, small intestinal bacterial overgrowth. So when we have a patient with T1D complaining of lactose intolerance while making changes in their dietary habits and everything, we should just do a basic simple test, which is predominantly a bedside test, which is a hydrogen breath test, and I think that will give you a lot of differentials coming out of that. And of course, you should screen that patient for celiac as well, celiac autoantibodies.
तो विद दिस
मेरा एक लास्ट क्वेश्चन है कि ये जो जितना वेस्टर्न पॉपुलेशन में सेलियाक डिजीज का प्रेवलेंस है उतना हमारे इसमें मेरे
नहीं
हिसाब से तो नहीं है।
नहीं है. This is why you
और
need
फिर
to do the
भी
hydrogen breath test, because
yes,
not every lactose intolerance could be because of that. It could be just because of a small intestinal bacterial overgrowth or even an IBS, or it could be anything. That's what I was saying, that you need to have the differentials done
right,
first. That's what point I was trying to make.
exactly, right.
So it was a very good session actually. तो अच्छे लगे, काफी अटेंडी भी थे हमारे इधर टाइप 1 के, and most of the questions have been answered. And the speakers, both the speakers, I'm thankful to both the speakers, Dayal sir and Dr. Agarwal, with the best of the talk. And yeah, pehla wala talk, it was like more a philosophical aspect to the type 1 diabetes, and second was about the growth chart. क्योंकि हम usually type 1 को treat करते हैं, but we do everyone follows growth chart in our clinic or not? There's a big question to be asked at the end of the day. So that's where this topic has been selected for our today's webinar. And आज महसूस हो रहा है कि हम कुछ किए हैं टाइप 1 को एम्पावर करने के लिए, एंड विद द हेल्प ऑफ डॉक्टर अमित, डॉक्टर ऋतुल, डॉक्टर मनीषा, हम लोग करते रहेंगे आगे भी. विल कीप ऑन एम्पावरिंग टाइप 1. सो प्लीज बी विद अस, help us so that we can keep community of type 1 growing and empower them. With this, I hand over the session for our concluding remark to either of Dr. Manisha or Dr. Mehak can take over it. Thank you to all the speakers.
Dr. Manisha, you take over.
That's okay. Thank you, sir, for sparing your time. और indeed बहुत ही insightful session था, और I learnt a lot. And thank you, Dr. Agrawal. I like we have a pediatric endocrinologist in our clinic, Dr. Anurag Bajpayee. So he has the habit of doing this. This is what I learned from him, the importance of growth chart. So it was a kind of revision for me. So thank you so much for sparing your time, and thank you, Dr. Rutul and Dr. Day, for joining us. Though we were almost like end of the session, but being all three of us as a founder member of Empower T1, it was great to be here, and thank you so much for everything you do.
तो आज 440 logins हुए थे. This is
That's
very
nice.
good news. Thank you very much USV and supporting team and everyone Empower team for joining. बहुत ही मजा आया, और ये सुन के कि इतने सारे लोग ज्वाइन हो रहे हैं, उनको इंटरेस्ट पड़ रहा है हमारे. यस, डॉक्टर सुभज्योति प्लीज.
Before I conclude, I will ask and request to all our physicians that I had a set of questionnaires. I'm circulating it by tomorrow about type 1. Please circulate amongst all our type 1, get their relevance, because it's a questionnaire of 4 pages with around 40 or 50 questions. So hopefully that will be one of our like Empower T1
Research project
paper for this upcoming international the conference in Bangkok.
Okay.
Yeah, IDF in Bangkok.
IDF.
Fantastic. That's a good
IDF,
initiative.
IDF.
Yeah.
Right. Great, Dr. Shubhajyoti.
So
I
it's all
on-
about collaborative and researchers.
Yes,
So
Yes, yeah, because that was one of our aim also, to do more of researches.
that's right.
So yeah, by tomorrow I think I will be circulating it.
fantastic. Fantastic.
Dr.
So just
Shubhajyoti,
before we end, I just want to wholeheartedly thank Dr. Deepak Dalal and Mayur for joining us as a speaker, and was at a short notice. And I should also mention two very important names of Empower, Mahek and Riddhi, who had been working behind the scenes in getting all our events organized and coordinating with the speakers, and doing the patient education webinar. And they have been selflessly been working in that Empower team. Quick request to all our viewers is that feel free to reach out to any one of us if you wish to collaborate with us on the Empower community. We are an open community, and we are open for collaborations with ideas and thoughts coming in. And also, please write to us. We have an email address, and maybe we can post this somewhere in the group, that we would love to hear from you on the topics that you want to hear from us. And just before we end, we have a very good physical conference coming up in December. I think that's going to be in Jaipur. That is the tie-up event. They are also collaborated with us, and will invite our physicians who are watching this to go reach out and register for that event, and we would love to see you all there. And once again, thank you, Team USB, for taking all the effort. Thank you very much. Good night. Bye-bye, everyone.
Good night.
Thank you. Bye.
Good night. Thank you.
Night.
Right.